Welcome you to this simple but yet important topic about the paraneoplastic syndromes. What about the gastric cancers? The gastric cancer can present in by three paraneoplastic syndrome. That is, first one is acanthosis nigricans. That is the velvety hyperpigmented plaques at the neck base as well as the shoulders. It is generally associated with insulin resistance, but however, a sudden appearance of acanthosis nigricans could indicate an underlying gastric adenocarcinoma. Secondly, there is a sign of lesser trellat. What does it mean? There are seborrheic keratosis, which are greasy keratosis which are present on the face or the neck. Sudden eruption of multiple seborrheic keratosis can be a marker for gastric or pancreatic malignancies. What about the virchoous nodes? When there are palpable left supraclavicular lymphadenopathy, that is also Troisier sign, they are the virchoous nodes. They are pathognomic for gastric cancer, but they can indicate other visceral malignancies too. Regarding the ovarian and the pancreatic syndromes, the ovarian carcinoma can present with dermatomyositis as a paraneoplastic syndrome. Pancreatic carcinoma can present with migratory thrombophlebitis, also known as Troisier sign. Renal cell carcinoma triad. Renal cell carcinoma can present as PTH related protein. It can secrete PTH-RP, which will cause elevated calcium. But what happens to the endogenous PTH that has been released? It will be suppressed. It can result in inappropriate erythropoietin excess, leading to polycythemia too. The renal cell carcinoma generally have a clear cell histology. That is, they have large cells with clear cytoplasm on microscopic examination. So the classic presentation will be a smoker who presents with hypercalcemia, polycythemia and hematuria, which is due to the renal cell carcinoma itself. The lung adenocarcinoma can present with hypertrophic osteoarthropathy. That means the digital clubbing, which is combined with painful periosteitis affecting the long bones. Sometimes in exams, they might just give you a painful periarthritis with the digital clubbing. And what is the next best step? The next best step should be based on our suspicion of the lung adenocarcinoma. Therefore, chest X-ray for pulmonary evaluation should be done. What about neuroblastoma? Neuroblastoma can cause opsoclonus myoclonus as the paraneoplastic syndrome. That is a dancing eyes with dancing feet. What happens in small cell lung cancer? In small cell lung cancer, it can present with Lambert-Eaton syndrome. I generally remember this as a small lamb. Like that. So, small cell lung carcinoma can present with Lambert-Eaton syndrome, which is autoantibodies against presynaptic voltage-gated calcium channels causing proximal muscle weakness. It can be associated with SIADH, which is inappropriate ADH secretion, and also Cushing's syndrome, ectopic ACTH secretion by the small cell lung carcinoma. Also associated with cerebellar ataxia, which is presenting with anti-WHO, anti-U antibodies targeting the cerebellar neurons. What about the squamous cell carcinoma and thymoma? The squamous cell carcinoma will present with elevated PTH-RP similar to our renal cell carcinoma. So, since there is elevated PTH-RP, the endogenous PTH will be suppressed because the elevated PTH-RP will be causing hypercalcemia, which will suppress our endogenous PTH. What about the thymoma? Thymoma can result in myasthenia gravis, that is antibodies against postsynaptic nicotinic acetylcholine receptors. So in any patient who is having myasthenia gravis, we should suspect them thymoma, and therefore a chest CT can be done. Pure RBC aplasia, that is red blood cell aplasia, can also be associated with the thymoma. So with this, we have come to the end of our paraneoplastic syndromes. All the best for your exams.